Good morning, good afternoon, and good evening to all of you joining us from all over the world. My name is Trisha de Jager, and on behalf of Oculus, I would like to welcome you to this special online seminar, which is part of our 125th birthday celebrations. The title of today's session is Biomechanics and Tomography, Novel Approaches for Ectasia Screening and Keratoconus Progression Analysis. Our two guest speakers today, I'm sure, does not need any introduction. They have worked over the years with the creation, development, and evolution in refractive screening practices and continue to do research to enhance refractive practice. Professor Belin, Professor Ambrósio, thank you. As always, a pleasure to have you present for us. Before we get into the topics of the day, a few technical things. If you have any sound problems or any technical difficulties, on the right-hand side, you will find a chat function. Please write it there and we will try and assist you where possible. And also during the talks, if you have any questions, you will also find a Q&A section on the right-hand side. Please write it in the Q&A section, and depending on time, after each of the talks, we will have a few questions. So with that, our first topic of the day is clinical applications of the Belin ABCD staging and progression display. Professor Belin, you are the presenter, so you can start sharing your talk, and we are looking forward to listen to you.
So what I'm going to be talking about this morning are clinical applications of the Belin ABCD progression display. So first, what was really the impetus to develop a new display? Well, obviously, first is what we've had in the past, which is Ambrósio, is vastly outdated. It was developed in 1947. It used a keratometer and an optical pachymeter, things most of us aren't even using any longer. And it also completely ignored what we now know is important, which is the posterior corneal surface. And that's not just me saying it, but in 2015, there was a published global consensus on keratoconus and ectatic disease. That was the work of the four major multinational cornea societies, Asia Cornea, Pan Cornea, U Cornea, and the Cornea Society. And what did they conclude? Well, they said in order to diagnose keratoconus, you need to have an abnormal posterior elevation, an abnormal corneal thickness distribution, and realize again that Ambrósio, the way we used to classify disease, didn't look at either of these. They also acknowledged that the best and widely available diagnostic test was tomography, be it either Scheimpflug or optical coherence tomography. And they went further to say that posterior corneal elevation abnormalities must be present to diagnose early or subclinical disease. Most of you are familiar with the Belin Ambrósio enhanced Ectasia display, or the BAD display as it's commonly called. That utilizes something we call an enhanced reference surface. That enhanced reference surface is designed to further accentuate the ectatic region. And we do that by removing what we call an exclusion zone from computation of the best fit sphere. Now, in the BAD display, that exclusion zone is actually a complicated algorithm that varies that exclusion zone between 3 and 4 millimeters, depending on a number of clinical parameters. But in moderate to advanced keratoconus, that exclusion zone almost always defaults to a 3 millimeter optical zone. And again, that works because by excluding that zone, what we've done effectively is remove the bulk of the ectatic region. So we thought about that and said, well, we've had years of experience with the BAD display, and we know that that works. Well, if it works because we're removing the bulk of the ectatic region, if we want to kind of classify or describe disease, we should look at that region. So as opposed to removing the exclusion zone, we examine the exclusion zone as it represents the bulk of the ectatic region. And that's, again, especially in the keratoconus eyes, that represents a 3 millimeter optical zone centered on the thinnest part of the cornea. And we came up with a new classification called the ABCD classification or grading system. A stood for the anterior radius of curvature, B for the back or posterior, C was the thinnest point, not just an apical reading, and D was not an objective measurement, but subjective spectacle distance visual acuity. We divided the anterior surface somewhat to mimic Ambrósio divisions. But again, we're dealing with, instead of diopters, radius of curvature. And the reason we use radius of curvature is diopters doesn't make a whole lot of sense when you're looking at the back surface of the cornea. In diopters, the back surface is a low power minus lens. But radius of curvature is really independent of orientation or index of refraction. And again, the back surface of the cornea, the index of refraction is cornea to aqueous as opposed to the anterior surface, which is air to cornea. Additionally, we added a stage 0 to more closely mimic the normal eye. If you kind of remember Ambrósio, basically every eye is at least stage 1, which really makes no clinical sense. That classification or staging is now integrated into the topometric keratoconus staging display. And here you can see a blow-up of that, and it's, again, part of the topometric keratoconus staging display. The actual classification of disease is actually the least clinically useful. It's really designed to do studies so you can group patients to determine kind of what's the best way to treat different classifications. Here you can see we have A0, in other words, a normal anterior surface, a marked posterior ectasia, B4, a moderately thin cornea, D3, but distance visual acuity is normal because the anterior surface is normal. More informative is actually the graphical analysis. So you can see exactly where everything fits. Here you can see that the corneal thickness is slightly above the 3 parameter, and the back surface actually exceeds 4. The most useful information for that specific patient is actually the actual numbers you can see here. So again, anterior radius of curvature, posterior radius of curvature, minimal pachymetry, and distance visual acuity. But the real goal of that initially wasn't just to come up with a classification system. It was to use that information and allow us to develop a progression display. So I get a lot of questions, well, why do we need a progression display? Can't we just use the bad display? After all, a bad display gives us an overall reading of the severity of disease. Well, it does and it does not. The Belin Ambrósio enhanced Ectasia display or bad display was designed specifically to separate normal from abnormal. While it's very useful, it is not specific necessarily for ectatic disease. It's designed for risk analysis for refractive surgery. Now, it can be used as one inclusion criteria for keratoconus studies, and we are doing that in a current study. The final D shows deviation from normal, but not necessarily progression of disease. Those are somewhat different. Now, if we look at the right side here, the ABCD progression display was designed specifically to allow us to follow and document progression of disease. It's based on one-sided confidence intervals. Again, one-sided because we're only interested if the cornea thins or if the back or anterior surface steepen. It allows us for documenting progression in spite of a stable anterior surface or stable Kmax and evaluates each anatomical layer individually. So, excuse me, here's an example again why we need a new progression display. And I mentioned here that the bad display is really designed just to separate normal from abnormal or refractive screening. You can see on the lower left a highly abnormal bad display, but that's post-refractive. The upper right is hyperopic LASIK. You can see it looks very similar to an ectatic cornea. And on lower right is endothelial dysfunction, marked corneal edema. All of these are abnormal. All of these will give us an abnormal bad display. All of these are not true ectatic disease. So getting back to that global consensus document from 2015, the other thing they concluded was that to define ectasia progression, we need to have a consistent change in at least two of the following parameters, and that the magnitude of a change needs to be above the normal noise of the testing system. In other words, you need to have statistically significant change. And at least two of steepening of the anterior corneal surface, steepening of the posterior corneal surface, or an increase in the thinning or rate of corneal thickness change from the periphery to the thinnest. And again, they further reiterated that those changes need to be consistent and above the normal variability or noise of the measurement system. But if we look at all the prior progression parameters that people have published, if you look at this entire list, everyone on this list, except for pachymetry here, is based on the anterior corneal surface. So again, it completely ignores the posterior corneal surface. And again, we know now and again, it's consistent with the consensus document, that not only is the posterior surface the earliest change that we see, but we can see changes on the posterior surface in spite of a stable anterior surface. Most of us recognize the limitations of Kmax, even though that's been the de facto parameter people have used for years. But the reliance of Kmax as both an efficacy parameter and an indicator of progression has resulted in irreversible loss of vision and delayed intervention at the earliest possible stage where progression can be detected. Again, I know in the US and many other countries in Europe, you have to document at least a 1 diopter change in Kmax. In other words, you have to have an abnormal anterior surface, and that abnormal anterior surface has to get worse. This is not normally what we do in medicine. We don't wait till the disease gives you an irreversible change. We try to prevent that irreversible change. We don't, again, treat high blood pressure only after someone has a stroke. The goal, or glaucoma, we treat them if their pressure is elevated. We don't wait for them to get field loss. But at the moment, using Kmax effectively, we're being told you have to wait till you have irreversible changes, and those changes have to get worse. So we want to develop a progression display to allow us to identify progressive disease or change at the earliest possible stage. And again, here we compare the AMSA-CRUMAC, which again uses only the anterior surface and apical reading, to the ABCD classification, which again is the anterior radius of curvature from a 3 millimeter zone in the thinnest point, which is the A parameter, posterior radius of curvature from a 3 millimeter zone on the thinnest point. C is not an apical, but the minimal corneal thickness. And D, which again is not going to be part of the progression display because it's not an objective measurement, is best spectacle corrected distance visual acuity. But we needed to determine the background noise for each of these parameters. Now, the A and B parameters are new parameters, and there were no published values for the inherent noise of those measurements. We also decided it was important to measure the noise in two different populations, both a normal population and an abnormal, meaning a keratoconic population. Now, the keratoconic population should be obvious because we're dealing with keratoconus, but in your older patients who have clinically evident keratoconus, the noise levels from the keratoconic population is more appropriate to utilize for a number of reasons. One, we're dealing with more advanced disease, and in your older, more established patient, the risk of rapid change in the older patients is lower, and the risk of waiting is somewhat lower. But in that young patient with very early or subclinical disease, we theorize that the noise levels more closely matches a normal population than one with moderate to advanced keratoconic disease. Also, we know younger patients have more rapid change, and here the risk of waiting is high. So we have two different populations that will allow us to compare to. And we developed, again, both an 80% and a 95% one-sided confidence interval. And it's not important for you to look at these numbers, but what you will see is what we would have anticipated, and that is the noise levels for the keratoconic population are higher than those for the normal population. And again, one-sided because we're only interested in things steepening or thinning. And this is the second iteration. Hopefully all of you have updated software. And this is the current Belin Keratoconus progression display. And we'll go over different features of this display now. The top part here is the graphical analysis of each of the 4 parameters, A, B, C, D. Again, I want to stress that D is not machine generated. It's an subjective measurement that the operator has to enter. If they do, if they don't, it won't appear. And again, confidence intervals do not appear for a subjective measurement. The machine automatically displays up to 8 exams sequentially in time and displays both the 80 and 95% confidence intervals. The green flags represent the normal population. The red flags represent the keratoconic population. And as you can see, you need greater change to reach statistical significance against a keratoconic population than the normal, which again, the keratoconic values tend to be more noisy. You can also show over here your baseline exam. It will default to the first exam, but you can choose any exam as baseline. You can also show here when you've done a treatment, and here in treatment we're really meeting cross-linking. I'll discuss this later, but as soon as you show that you've done a treatment, confidence intervals will not appear after treatment, since the confidence intervals were not developed for post-treatment or post-cross-linking eyes. In addition to this graphical display, the bottom part shows tabular a number of parameters, both the date and hour of the exam, the ABCD classification, the overall final D reading, your progression index average, ART max, K max, Q values, and a number of the anterior parameters that people have looked at in the past. So again, this is just, again, highlighting what we just discussed. Here you can, again, identify the baseline, which is what you do here. Again, it will default to the first, and you can identify when you've done treatment. It will default to show both the green and red normal and keratoconic populations, but you can choose to only show one by clicking on that value. And here's an example showing the differences if you choose on the upper one, the normal population, and the lower one, the keratoconic population. Why would you do that? Well, if you're looking at an advanced keratoconic, mainly for medical legal reasons, you would want to display only against the population that you're making your clinical decisions based on. In other words, if you had a young child here, you would want to show the green, because here you've reached statistical significance more than if you compared it against the red. I already mentioned that once you show that you've done a treatment, you'll notice none of the confidence intervals appear after that cross-linking indication. The treatment is indicated by a hatched black line. So again, all the exams below that will not currently show confidence intervals. So let's look at some clinical examples. Here is a 15-year-old with advanced keratoconus who's been followed over 7 years. Now this patient, actually, we can retrospectively go back and analyze past patients. And here again, you can see it's over a 7-year period. You'll notice the ABCD classification. This is severe disease. If you look at the bad Ds, they go from 11 all the way up to nearly 16. And here you can see again, on the anterior surface, continued progression of disease. On the posterior surface, again, continued progression of disease. And corneal thickness, continued progression. This operator, this surgeon did not enter visual acuity, so as you can see, again, it does not appear. And here you can see really by the second exam, this person had clinically significant progression in almost every single parameter. Corneal thickness required the third exam. But this doesn't really demonstrate the value of the exam, because if you look at K-max down below, you'll notice it continues to progress from 56, 60, 64, 64, almost 65. But let's look at some other examples that will clearly show the clinical value of the ABCD progression display. Here's a 15-year-old with very early keratoconus. You look at the bad Ds here, it's just about 3. And if we look at Kmax, you'll notice Kmax is effectively completely stable. It's blown up here on the right, 46.1, 45.5, 45.8, really no statistical change. And if you look at the anterior surface, the A parameter, again, it shows no really significant change. But look what's going on in the back of the eye. And by the second exam, we've had progressive disease past the 80% confidence interval. And by the third exam, we're well past the 95% confidence interval for progressive disease. So this is an indication here to treat this patient in spite of the fact that for most insurance companies, this patient may not meet criteria, a stable Kmax, but documented progressive disease. Here is another, it's a 16-year-old with progressive subclinical disease. If we look at Kmax, goes from 48.9 to 49.8. And if you're in the US, your insurance company would decline this because you haven't yet hit that 1 diopter criteria. I know in some countries it's actually 1.5. Well, look again here on the anterior surface. Again, it's a 15-year-old with early disease. Notice the bad Ds are only in the 2 to 3 range. The anterior surface is well past the 95% confidence interval. The posterior surface is well past the 95% confidence interval. And the corneal thickness is well past. Here we have every single parameter past the 95% confidence interval for significant change, in spite of the fact that we have what would not meet in most countries criteria for treatment, or at least approved criteria for treatment. Here is an 18-year-old, again, stable Kmax. Here we're showing a bilateral display. Notice again, 48.6, 48.4, no change. 46.2 actually got better to 44.2. And if we look at the right eye here, we'll notice again, no real significant change on the anterior surface. The posterior surface by the second exam just reaches the 95% confidence interval, and corneal thickness at the thinnest point just at the 80%. But if we look at the left eye, again, posterior surface well past the 95% confidence interval. So both eyes here show progressive disease in spite of the fact that we have a stable Kmax. We have a stable Kmax. Also, we have a stable anterior surface. This is where you want to intervene. You want to prevent loss of vision, not wait till you have a loss of vision and then wait for that loss to get worse. Well, the progression display is not just useful for earlier subclinical disease. This is a patient with fairly advanced disease. If you look at the classification here, if you look at the bad Ds, they're all above 7. So this is no longer earlier subclinical disease. But again, if you look at that anterior surface, there's no statistical significant change. And if you look at Kmax, 51.2, 52.1, 51.9, again, 50.3, nothing reaches that criteria. Actually, it gets a little bit better. But again, if we follow, we can see here that the posterior surface by the last exam is past the 80% confidence interval, and corneal thickness is past the 95%. So again, here we're showing progressive disease in spite of the fact that, again, that the anterior surface is unchanged. So how do we diagnose progression of keratoconus? Well, we recognize that there's disassociation of clinical progression with changes in Kmax. There's now a topographic-based classification system that recognizes all the anatomical layers, and a tomographic-based progression display that documents when we have statistically significant change. And I said earlier, this may be used actually in your older historical files, so you can go back and review past information with the new software. So I mentioned right in the beginning that if you define that a treatment's been done, and again, we're talking about treatment, really cross-linking, all the confidence intervals after treatment will drop out. And that's because progression parameters after cross-linking have been unknown. And as I said, currently the confidence intervals will drop out or will be removed once you've indicated a cross-linking treatment. The next version of the ABCD will incorporate post-cross-linking parameters. I've worked with the group in Zurich, and we've begun looking at, again, the noise measurements post-cross-linking. This is a study that we've already submitted. We looked at 41 eyes that ranged from 11 to 60, age from 11 to 63, who were 9 to 23 months post cross-linking. I don't want you to spend too much time, but these are the 80 and 95% confidence intervals. What we did notice here, however, that the noise levels were considerably, I want to stress the word considerably higher than previously reported in either normal or keratoconic. So we're a little bit uncomfortable with the initial study, and we're currently repeating these measurements at 2 different institutions with patients who are at least 24 months or 2 years post cross-linking. Eventually, once we get that information, we're actually analyzing the data now. This is what you will see, and that will be new gates, probably use the color blue to indicate post cross-linking will appear, but they won't appear till after a certain period, whether it be 1 year or 2 years post cross-linking. And again, to allow us to determine when and if patients need retreatment. We do know that some patients probably do need retreatment, and we need a way to follow these patients long term. So I was given 25 minutes. I'm a little bit under. I want to thank you all for your attention, and I figure out how to hand the program back over.
Thank you, Professor Belin. I think the audience can greatly benefit from the knowledge you share. We definitely have time for 2 or 3 questions. One of the questions I think that you get asked quite often is, how long between follow-ups do you wait? Does it depend on age of the patient, or what's your criteria?
It definitely depends on the age of the patient. Obviously, you have a 40-year-old patient who's been relatively stable. Probably I'll see the patient in 6 months the first time, and if it's stable and no change, yearly thereafter. If I have a 15-year-old, I'm going to see that patient initially probably just in 6 weeks. And then if it's stable in 6 weeks, maybe 3 months, but I follow that patient much closer. Again, that young patient, I'm going to be using those normal parameters, which are tighter. But again, the younger the patient, the more frequent that we will see the patient.
Okay. And then another thing you mentioned, you set the baseline examination usually around the first time when you see the patients. Is there any time where there's a reason why you will set the baseline at another examination?
Good question. Really, the answer is going to be, if you're doing certain studies, you may want to do comparisons later on. But normally, it will default to that first exam, and that's normally what's done. For most uses, that's the best application.
Thank you. And then I think a last question, what is your criteria? When do you treat a patient? When do you cross-link the patient?
So let me go back to that question before this. Obviously, if you've done a cross-linking and you want to follow the patient, then you have a new baseline. It's the post-cross-linking data. So you're not going to go back and pre-cross-linking. But basically, you're looking for change to a baseline exam. And that baseline exam, once you've cross-linked, should be the exam after cross-linking. You wouldn't go back to the first. When people cross-link is a personal decision, and it varies greatly by country, partly also because of coverage. In the US, we have fairly restricted insurance coverage that hopefully over time will change, and 95% of the insurance companies still are using 1 diopter of K-max. We are submitting tomographic data, and a lot of insurance companies now are recognizing that we can show change earlier. But again, that varies. It really varies too much by geographic region and by individual practice to give you a good answer to that.
Well, thank you. And thank you for the presentation. I think, just as Professor Belin mentioned as well, if you have a Pentacam and you do not have the latest edition of the Belin ABCD, please contact your local distributor who can upgrade your software to the latest version. So the next topic for today is the artificial intelligence for enhancing Scheimpflug tomography and biomechanical assessment. So, Professor Ambrósio, I've made you the presenter now, and the floor is yours.
Thank you. Thank you, Tricia. Good morning, good evening, good afternoon. Hello, Michael. As always, a brilliant talk. Congratulations. I hope all is well with your family. I know you are recent grandfather, and I hope everything's well.
Thank you.
Wish all the best. This year, I have a special announcement as the president of the ISRS. We have multiple sources of information for refractive surgery, including the JRS, and we have a special code, ESRS 2020, so please consider visiting us at our website and learning more about the society and eventually being part of our family. It's an honor to participate in this webinar on the talk related to artificial intelligence for biomechanics and tomography. These are my disclosures, including, of course, Oculus, with who I had the privilege to collaborate with over the last more than 15 years now. And of course, I want to mention my collaboration with the BRAIN, the Brazilian Artificial Intelligence Networking in Medicine, which is completing 10 years. So Oculus is completing 125 years, and the BRAIN is now completing 10 years. So it's a very special year for all of us. And I have to acknowledge my collaborators in Brazil and Portugal so that I can present all this work. It's very important that we try to make things easier. We are overwhelmed by technology, by information, and this overwhelming, we have to think about ways of making life simpler, but not in a simploric way. So it's very important that we go to the artificial intelligence understanding. It's a true revolution in evolution, and artificial intelligence should be understood as a branch of computer science in which we can recognize patterns, make predictions. We have supervised learning and unsupervised learning. Supervised learning is when you have label for the data, and supervised learning, you don't have the label data, but the machine learning processes will find clusters, will find patterns, and try to make some predictions about the data. The reinforced learning is very important. I will discuss very much about it today because it's our ability to keep ourselves getting better and better. I think it's very much in conjunction and relational to what we are doing in this planet to evolve. Machine learning has a special part, which is deep learning. Deep learning allows us to go deeper into the source of the data and go beyond not over the data that we have available, the parameters. So we can create new parameters, and deep learning is probably the next move that we are going to use for really improving the ability to get the data and make clinical decisions. I like this philosophy in which we have to understand ourselves and understand what we are trying to achieve, the enemies. So what are the goals on diagnostics for keratoconus and ectasia? We want early diagnostics, we want screening, we want prognosis. We just heard Michael Belin's great, brilliant talk on the follow-up, which is important, but we want to stage to see the severity of the disease. Patient education is going to be very important. And of course, Michael just mentioned the point on the bureaucracy for medical treatments. You need to have documentation, and individualized treatments will come from these technologies. We have the multimodal imaging, since topography, Scheimpflug tomography, biometry, ocular wavefront. We have all this data along with corneal biomechanics to complete what we say as multimodal corneal imaging. Multimodal corneal imaging is going beyond but not over. Beyond but not over the detection of keratoconus or the enhanced ability to characterize ectasia susceptibility, which is different when you do therapeutic procedures in patients with true keratoconus and ectatic diseases. We broke the paradigm, so we have to understand that the screening for ectasia susceptibility is different than diagnosing ectasia and eventually staging the disease and doing the follow-up. But these are the whys that we need the data. Basic concepts for screening are very important. We have data acquisition and then parameters. Michael made a beautiful point on his display that look at the precision. The precision is the repeatability of the parameters, the standard deviation of multiple measurements done in the same subject, which is different than the accuracy, which is the correctness of the data considering a reference value. This data will be presented in clinical displays, and artificial intelligence is very powerful to enhance the ability of this clinical data for making good decisions so that we can help the patients the best way as possible, which is, by the end of the day, always the goal that we should have in our mind. The Pentacam, for example, which is now a multimodal imaging with axial length and ocular wavefront with the new tools available in the market, would give you a lot of information with other situations like angle closure glaucoma, not only keratoconus, but when you see angle chamber angle, AC depth, AC volume, you have different situations and you can see how the patient is sitting so that you can really screen for the disease. The Belin Ambrósio, which is now over, I would say, 12 years, we have the deviation from normality that combines front and back surface enhanced elevation and thickness profile. Michael just made a brilliant talk, and the precision here is the threshold if you see that this patient has or not a statistically significant change in the front-back surfaces or thickness mapping. When we think about ectasia, I always consider this 1998 publications. These publications lead to the pathophysiology of ectasia, high myopia patients treated by LASIK in which biomechanical impact caused ectasia to progress, and a patient with a forme fruste keratoconus, which is a misleading term, I agree. But forme fruste keratoconus here is a relatively abnormal cornea characterized here by the front surface curvature map with the asymmetric bow tie. The pathophysiology of ectasia, though, is related to innate biomechanical properties and the impact from the environment. Actually, any disease in medicine can be looked at this scenario, and eye rubbing along with laser vision correction procedures will be very important. A very major point is that any cornea may develop ectasia, considering the impact and the resistance. A very nice series of cases with over 300,000 LASIK procedures was demonstrated by Siv Schallhorn, in which you can get cases with a normal topography and even tomography in the ectasia cases, actually 30% of these cases, and also cases with a pre-op abnormal topography and tomography, it would be 1% of the stable no ectasia cases. So what is forme fruste keratoconus? Forme fruste keratoconus is a complex term, and when you think about the question, is topography enough? Yaro Rabinovich would say, yes, topography is enough because in cases like this, which he calls forme fruste keratoconus, because there is abnormal topography, typical keratoconic topography, in a patient with a normal slit lamp and normal distance correct vision. Steve Kleiss would say that the fellow eye of this patient will be a forme fruste keratoconus, and sometimes he uses the term unilateral, which is sometimes misleading. My opinion is that all these cases, they are asymmetric ectasia, and I can even claim that this is not an opinion, this is a fact. And we need to go beyond, not over the front surface here, so that we can see if there is an abnormality in this eye, so that we can demonstrate if this is a forme fruste eye, or susceptible eye, as I prefer, or if this is a true unilateral ectasia due to environmental problem. So the mild keratoconus is a very nice term by Jay Krashmer in a brilliant talk from the Cornea Sub Day at the Academy a few years ago. But I would say that there is no consensus. And my humble contribution is that ectasia susceptibility will be a better term to define forme fruste keratoconus. And forme fruste keratoconus is definitely not. It's a concept of a clinical situation in which the disease is present, but in a very, very mild with a subclinical, subsymptomatic situation. It's not a topometric classification. In situations like this one, in which the patient had LASIK with a thin flap and PTA of 0.36, a little bit of a yellow in this 1.5 scale from Smolik and Kleiss, a lot of people would say, now that I know that there is ectasia after LASIK, this is a pathognomonic of forme fruste keratoconus. We looked at the variability of subjective classifications from corneal topography maps, first sending this 1.5 scale and then sending the 0.5 normative scale, which is called the holiday scale in the Oculus Pentacam and keratograph. We asked the colleagues, 11 colleagues classified based on the criteria from Brad Random on 0, 1, 3, and 4. Interestingly, the first scale with the classifications vary from 0 to 3 with a mode of 0. The second classification, they had a 0 to 4, but still a mode of 0. So the variability is very important. This data was available, but we didn't have the Pentacam Belin Ambrósio at that time. But we can use the raw data, the U12 files, and calculate retrospectively. And the D was 2.46, much higher than 1.5, which is the threshold I would recommend. The Artmax is another index that here would say that this patient has ectasia susceptibility. I don't think it's a keratoconus, but ectasia susceptibility. When we look at the enhanced ectasia study, in which we had precious data from 105 pre-op ectasia cases and stable cases, we had a pre-op from 3,278 cases, you see the IS value, the inferior-superior asymmetry index, which some people call Habilowitz, will be very specific. In fact, 98% specific, consider 1.45. This is important because people are obeying. They are looking at topographies, but it's not sensitive. It only detects 22.9%. The bad D, which was not available when this surgery was operated, would be much better. Will go to 59%. However, the specificity is a little lower. Interestingly, we have to understand the objective parameters, the populations, and Bernardo Lopes, in his brilliant thesis, he looked at the data on patients that had normal topography from the fellow eyes of asymmetric cases, and also this pre-op, 60 of this pre-op that we had available that time. We used artificial intelligence, and then we had the Pentacam random forest index, which would detect 74.3%, but you still have cases here. So it's going beyond but not over into the biological properties, and corneal biomechanics is now available with the Corvis. The Corvis is ultra-high-speed Scheimpflug camera, which takes in 31 milliseconds 140 frames. And these frames, you can see a very abnormal cornea with a mild keratoconus and a very thick cornea with an ocular hypertension, which is kind of the opposite of a weak cornea. And you can have deformation amplitude, velocity, and all these terms that can be combined into the corneal biomechanical index from the Corvis. And this is the work that has been done in conjunction with Paolo Vinciquerra. I would just show a patient that came to me this week. This patient was asked me to see as a second opinion for doing a Athens protocol, cross-linking plus PRK for ectasia, late ectasia after PRK. And you can see the front surface data. It's very abnormal. Interestingly, the tomography data, you have a thin cornea, but with not a normal posterior elevation. The CBI post LVC is 0. So it's pretty much important to understand this patient has haze and definitely doesn't need cross-linking. It can be an ultra-thin cornea after a PTK to improve that. Our ability to look at tomography and biomechanics goes into the domain of the TBI. This is the JRS Integrated Scheimpflug Tomography and Biomechanics paper that we published in 2017. And we looked at 94 cases with a normal topography based on objective criteria, and we had a sensitivity of 90.4%. Actually, it was virtually perfect for the clinical ectasia cases, considering the normal eyes. The epitomize of ectasia susceptibility is what believe we are trying to achieve here. And interestingly, the random forest was the best with before and out cross-validation. So we have cases like this one. This is 27 years old that comes eventually with a 2015 distance correct vision and eventually good candidate for laser vision correction if you just think about front surface, good vision, relatively good age, thickness. But look at the posterior flow. There's a little bit of yellow here. Is this patient abnormal? When we go to the TBI, this is a 0.41. This is a relatively susceptible cornea. You see the stiffness parameter is in the red range, the ART8. This is a patient that has a fellow eye with a mild clinical keratoconus. So this patient is a good example in which you enhance the sensitivity for detecting high susceptibility for ectasia, which you can call Forme Fruste or not, but this patient has abnormal cornea in the right eye. This is a very similar situation from the case that we first published in 2010 That's when I coined the term ectasia susceptibility. This patient is still stable. If you look of the tomography data, you have a borderline bad D, 1.37, 0.19 of the PRFI. This patient may qualify for LASIK. But if you see the tomographic and biomechanical integration of 0.78, this is a very abnormal weak cornea. The patient has 20/20 plus now this is correct vision, and this patient does not have keratoconus. She has ectasia susceptibility. Very much of interest is the son of the patient that has this is correct vision of 20/20 and a little bit of a possible in the TKC, a little asymmetric bow tie. But this is the patient that we have to really tell them not to rub the eye and follow up. I don't think cross-linking is indicated now, but definitely the Belin ABCD should be taken care in 6 months from this measurement, and this patient thankfully is still stable. Both eyes can occur with a bilateral form fruste, and this is the best example of that. This is an identical twin sister, and all the measurements in one of the sisters were normal in the front surface. Here is the placido disc and the Scheimpflug topometric display, but the TBI is abnormal. And this is a very asymmetric ectasia, which is, by the way, interestingly, a very interesting point. This is one of the patients that I have learned more in my career. The patient had high myopia, presented for laser vision correction. We decided the enhanced elevation was normal, 1.27 in the right eye and 1.07 of the D in the left eye. Arcmax was a little low, but we decided to go for SMILE. SMILE is a procedure that I found myself very much in agreement with the benefits of SMILE, because we have less biomechanical impact, but you still have a weakening because you're removing tissue and you're weakening the cornea. And also you have lower dry eye indices. You still impact the ocular surface. But this time it was 2014 when I started doing it, and I was just finishing my learning curve, and you see how smooth it is using Dan Reinstein's technique. You identify the front surface and then the posterior surface of the lenticle. And then these patients, they do very well. These patients did really well. In the first week, she got 20/20 plus in each eye, gaining vision, better than the this is correct vision. She was very well in the first year and second year. She did not come back in 2017, but when she comes in 2018, she was complaining with decreased vision in the right eye. 20/100 corrected to 20/25 with a -4 of cylinder. This was a patient that I was really unhappy to see that she developed ectasia. The left eye was still relatively stable, and you can see here that in 2016 with 20/25 plus, if I would be careful to look back at the posterior elevation, I would have been able to detect the abnormality. This patient has ectasia, no question. The left eye epithelial thickness is very handy for that. Patient was advised not to rub the eye, and the treatment was properly done with a corneal ring along with a transepithelial cross-linking, and she did very well. But what I have learned from this case, we had the data from the pre-op, and the TBI was 0.72 in this patient in the right eye and 0.25. So she was a susceptible cornea, and if I had that data, I probably have prevented this case. So we go from SMILE to frown, but back to SMILE again. But the interesting thing is not everything is a SMILE. We have to keep ourselves moving. We have to keep ourselves moving and evolving. Some reports of lower accuracy, even though the TBI is the best parameter, if you compare with any other parameter, the TBI is not perfect, and we acknowledge that, and the sensitivity can get better. So these reports lead us to the need for the optimization of the TBI, now with a higher number of normal topography cases, and these cases allowed us to do more training and more testing and machine learning algorithms to improve it. So here is a summary of this work that has been very nicely done by Deleuze Leon from the brain, in which we improve the sensitivity even for the clinical ectasia cases. You have some normal cases now up here, which I believe these are the cases that are really susceptible, but from 75 to 85% plus, you improve the ability to detect the normal topography eyes. Some cases down here are truly the cases that are related to the unilateral ectasia, and you see an enhancing of sensitivity without losing sensitivity comparing to the classic version 1 TBI. This will be the very good example of unilateral ectasia. The patient did well with a corneal ring in the right eye and very stable in the left eye. He moved to London and everything that could be done in his eye was measured. Everything normal, including epithelial thickness and the Alanside and the Mianga-Canal score available on the Orbiscan. He came back for a follow-up in 2018, and he was still normal and stable in the left eye. So this is a very unilateral ectasia, which is in agreement with the consensus that Michael just pointed out. True unilateral keratoconus does not exist, but ectasia can occur secondarily to a purely mechanical process, and it can be unilateral. When we consider the paradox of AI, is that AI is very important for ourselves today. We have AI in our smartphones. We have AI everywhere in our lives. Individualized medicine will benefit from AI, but we still need to have humanized medicine, and patient education is a must. The medical mission to heal few times, to relieve often, to comfort always is in agreement with our campaign, the Violet June. And one of the messages of the Violet June is that eye rubbing or scratching the eyes aggravates keratoconus and may even cause ectasia. This is not the same thing, and appreciating the difference is a huge step forward for understanding corneal ectasia and keratoconus. So screening for ectasia is multimodal. We need artificial intelligence, and this is a very nice summary from the patients that have low susceptibility, in this case may have even microkeratome LASIK. Some of the cases will benefit from PRK or trans-PRK and SMILE. And then if you go to the yellow to orange, you're probably going to go for a fake IOL. If you go to the red, maybe you are a therapeutic procedure which has to be differentiated. Another aspect that I didn't mention is the relational tissue alter. This is the impact from the procedure that we can use artificial intelligence to measure, considering the data that we have. And of course, consider doing all the best for helping the patient. Thank you very much for your kind attention.
Thank you very much, Professor Ambrósio. As always, a very informative talk. So we're going to go to some questions now. I think questions that's quite often asked in general, is the TBI an average of the CBI and the BAD final D?
Well, thank you very much for this question. And this is definitely one of the most important concepts. The TBI is an advanced AI with random forest. TBI is not the average of CBI and BAD. What we are doing is much better consideration of artificial intelligence for the data analysis. So we have more data and much better analysis. It's just a huge step forward in terms of ectasia screening. The CBI has its own value along with the BAD, but they are linear regression analysis. So they are much different than the TBI. That's why you have cases that you have a higher CBI and a lower TBI and vice versa with the BAD as well. Thank you for this question.
Thank you. And then there is a question for Professor Belin that just came in as well. Is the ABCD progression display, the confidence intervals, is it applicable to the Asian population?
Great question. My assumption, that's all it's going to be is an assumption, is the answer will be yes, because we're looking at change, not an actual value. We do know, and we've published this, that the normal values are different in different geographic populations. But the progression display is actually kind of what Renato mentioned. It's based on precision, not accuracy. So it's based on noise levels, not necessarily a specific number. So my assumption would be is while the bad display does need some adjustments for different geographic areas, the progression display is a noise measurement, and my assumption would be is that would be very similar throughout geographic areas. Great question, though.
Thank you, Professor Belin. then another one for you, Professor, is there any of the parameters that carry more weight to make a decision when it comes to progression?
So I'll kind of reverse that and say my least comfortable parameter is corneal thickness. And the reason for that is we know that corneal thickness will vary throughout the day. When you first wake up, your cornea is thicker, particularly if you have even mild endothelial dysfunction. But when we do noise measurements, they're repeated measurements really at the same time. So my least comfortable parameter is corneal thickness. In general, my guidelines are I like to see at least one parameter at the 95% confidence interval over 2 exams, or 2 parameters at the 80%. 2 parameters at 80 is effectively, from a statistical point of view, the same as 1 at 995. If you do 20% of 20%, it's 4%, so it's 96%. But again, my least comfortable parameter is corneal thickness. And if I only had a single parameter change in corneal thickness, I would probably watch that patient and repeat the exams a few times. And I think that's just normal because of the limitation of our reproducibility studies.
Thank you. Thank you. Is there any other questions? I'm not seeing anything coming in at the moment.
There was one question after Michael's first talk, not directly related to progression, but more diagnostics using tomography. I think a question which came up already many years before, difference between best fit toric ellipsoid and best fit sphere. What do you prefer, Michael, and why?
Okay, so I know this is this constant decade-long discussion. A reference surface is a reference surface. It has nothing to do with the accuracy of the display. And I always use the example, you can measure the height of a building from sea level, from the ground floor, from the basement. These are all accurate. They're all going to be different. What we compare the data to doesn't affect the accuracy of the data. It will affect the appearance. I use the best fit sphere because it gives us the most visually intuitive display. You can see the ectatic region the easiest, and actually that enhanced reference surface makes it even easier to see. You can use any reference surface you want, but then you have to generate all new normal values, and they will be different depending on the reference surface, or also different depending on the optical zone you use. And I know some people use a 9mm optical zone. All of our published work is based on an 8.0mm optical zone. The reason I don't like a best fit toric ellipse is because it will fit the cone better, and that's not what we want to do. A conical cornea is a toric, and it'll fit better. But it's kind of like looking, if you put a red balloon in a room painted with red, it's harder to see. So I want to put that red balloon in a room painted white because it makes it much easier. So from a visual inspection, a best fit sphere is the easiest and most intuitive clinically.
Thank you. And then one last question is to Professor Ambrósio. Is SMILE your first choice for susceptible ectasia patients?
That's a good question. While I love SMILE, I love the first day of SMILE, I still have to acknowledge that PRK, surface ablation, has a lower impact on the corneal biomechanics than any lamellar procedure, including LASIK and SMILE. SMILE is in between PRK and LASIK, but surface ablation is the best procedure in terms of biomechanics. Eventually, the best procedure will be even a phakic IOL. So you have even to consider that, or eventually going inside the eye for lens replacement. But it's very important that we acknowledge that the SMILE is a great procedure, has a huge opportunity to improve dry eye and ocular biomechanics and predictability eventually. All these considerations does not lead SMILE to risk-free for ectasia, as that's the first and ever only ectasia that I had in my career. So I would believe that I really pushed the limits, and I learned tremendously how to even understand the problem and treat the problem in all senses, including patient counseling, doctor-patient relation. It's a huge process of involvement, and learning from the pre-op data with the TBI was just an extra plus in this interesting situation for treating this patient.
Thank you. And I said it was the last one, but to conclude the session, the very last one, as an eye allergy can cause ectasia and keratoconus, what should be the counseling for the patient with the eye allergy?
I would say that first, don't rub the eye. If you have the caruncula, which is easily rubbed, and you can relieve you're eager to rub the eye, just rubbing the caruncula without pressuring the eyeball. Of course, treating the allergy, go to a doctor and have you can treat the allergy. You can go for allergy control, and today I'm using a lot vitamin B2 orally, which is a very much non-invasive way of enhancing the natural cross-linking. So don't rub the eye, treat the allergy, visit your doctor, do a Pentacam and a follow-up with the ABCD. That's what you need to do for a very nice care for the patient.
Thank you. Thank you very much. And I think with that, our session has come to an end. We've passed the hour. I would like to once again thank you, Professor Belin and Professor Ambrósio, for giving these talks today. And I would also like to thank you, our audience, for taking time out of your schedule to listen to us today. Furthermore, I would like to invite you to visit our online show in celebration of our 125th birthday. There's more info about the products and some other sessions. And with that, I hope you stay safe. Good evening, good afternoon, and enjoy your morning for those still in the morning. Bye-bye.
Thank you. Take care, everybody.
Take care.
Thank you,
Good to see you. Bye-bye.
Bye-bye.